Welcome to the 25th anniversary of the Design of Medical Devices Conference. That's 25 amazing years that this conference has been going on. My name is Hubert Lim. I'm the director of the Earl Bakken Medical Devices Center. I took it over 2 years ago through the leadership of Dr. Art Erdman, who had initiated the center. Now, I do know that you all have conferences and events all throughout the year, many of them, and we do appreciate that you selected this conference to come this year. Now, I will say I do believe we are a unique conference. It is on MedTech, where a lot of conferences are focusing on different topics and different sectors. We have a unique opportunity to cover many different fields in cardiovascular, in neuroengineering, orthopedics, AI, digital health, all in one meeting. And also we've worked very hard to bring together many of the different sectors. So we have, the government, academia, industry, and also patient foundations. In addition to that, we've tried to incorporate engineering, medicine, science, policy, business, and as you can see from the program, we focus heavily a lot on trainees and building the next innovators, the young generation. So we hope that you'll see the breadth of that in this meeting. I would like to say that at lunchtime, please attend during the keynote lunch. Dr. Art Erdman is going to provide a great history in the last 25 years of this conference, but also of the Earl Bakken Medical Devices Center and the local medtech ecosystem with amazing panelists who are going to share what they've observed over this 24 years. So it's going to be very exciting. But with that, I would like to at least share a few insights and observations, my opinions and my thoughts that I want to kick off the meeting with. So where were we 25 years ago? I think some of you may remember, may not remember. But I think some of you remember the iPod, 1,000 songs in your pocket. Back then it was amazing. Now if you look at this, it's clear that we've come a long way in technology. Can't forget the Nokia phone. I love this phone. Now, of course, I don't know what you could do with it, but it was a very exciting, innovative technology at the time. Google started to ramp up at that time. Wikipedia started that year, 2001. And we can't forget the Segway, which managed to make it into movies. This is a newer generation that appeared in that movie, but came out in December 2001. But there's been a tremendous boom, and I think we can all feel it in the technology realm. Smartphones pretty much are computers in your pocket. I cannot say enough about this. ChatGPT helped prepare some of my slides today. It was very easy. It took like 30 seconds, and it created a beautiful plot. AR, VR is taking over, and we've seen drones and robotically controlled devices. Waymo, even though there's still some glitches, as we see funny videos on TikTok, they still are pretty impressive in terms of being able to have self-driving cars, at least Ubers or taxis that can take you around. I think what's been quite phenomenal is the ability to have robotic manufacturing and a plant where you could have things that are being shifted around within the plant with robots and automated vehicles. So that has been amazing. What about medical technology 25 years ago? What I looked at and was researching to do this exercise, I was actually astonished. I mean, we had the iPod and we had the Nokia phone, and I thought, okay, if you think about 25 years ago, probably old-fashioned technology, nothing impressive, but we were pretty impressive 25 years ago when it comes to medtech. So you got to hand it to the medtech industry and ecosystem. We had an artificial heart. We had a keynote speaker last year talking about this. We had a cam that could go and you could swallow it, that could track images through your intestine. We actually had a kind of, watch that you see a lot of excitement around, but this was using electrical current to pull out fluid from your skin that would have glucose molecules that could then sense your glucose levels. And we had telesurgery going on 25 years ago. Now you could search limitations to all of these, but these were happening in humans, in patients. In my specialty where I work neurotechnology. In 2001, a company started where they were implanting 100 shanks of electrodes into the cortex to control robotic limbs and computer interfaces in wheelchairs. That was 25 years ago. Deep brain stimulation got FDA approval for Parkinson's disease in 2001, and in my specialty, cochlear implants, started to see a major rise in acceptance and adoption. So where are we now with MedTech? And what's interesting, it's not a contrast, but it is something that shows you that as technology starts to have its inflection point, you start to see MedTech having great boosts as well in their inflection point. And so what has happened with MedTech, from what I can observe, is that the technologies that we have developed started to be refined and smarter and safer and more accessible, which is amazing. That's what you want. You want MedTech to be innovative, but then make it to the patients. And we saw that in the last 25 years. We should be proud. Minnesota did one of the, well, it was the youngest, but now it's one of the youngest cochlear implant surgeries in a 2-month baby. This is a kind of neurosurgery, otology surgery, and it's done in a 2-month-old baby for restoring deafness. A project that I've been working on to develop a new type of auditory nerve implant. You saw the BlackRock array that has the percutaneous connector. This is all implanted now, all contained. And we're going to be starting our first patient next week in Germany. We're putting in 400 electrodes, wireless modules, into the visual cortex. And Paragenomics just implanted their first patient, 421 electrodes. So all of these are becoming much more accessible and capable, and the surgical approaches are getting massively improved. Another big win for Minnesota, this was actually a student that was a TA of who co-founded this approach, Histosonics. They'll be able to use ultrasound, now doing surgery, but doing something, that technology that was around for 30, 40, 50 years, being able to do precision surgery to lesion tumors. In the brain, they're also doing this to have surgical approach, and SciTech has a device. There's also ability to do blood-brain barrier opening with ultrasound to allow molecules and genetic alteration and cellular modulation. Now this pill cam that Dr. Ken Washington presented for Medtronic 2 years ago has been impressive. It's still a camera, much improved, but now able to do predictive analysis to see if you have any polyps or cancerous tissue in the gut, in the intestine. The glucose sensor, way improved, but more accessible, now out to a year, where you can have a capsule that's implanted underneath the skin and tracking and having predictive characteristics. And of course, this has been amazing. I couldn't capture this all, so I had to ask Agentic AI on Google Gemini to plot this, but you could see multiple companies pushing robotic surgery. So where does this take us now for the next 25 years? I think it's going to be quite revolutionary, because you've seen all the technological inflection happening, and we can feel it. I mean, our lives are changing day to day. It's hard to keep up with all that's coming out, but the medtech industry is going to embrace this, and we're going to see many things, not only from the innovations and the technologies, but also on the scaling and manufacturing, and also in digital health. And so what we believe is going to, or I believe is going to be happening, and many of you are seeing this, is that we're going to see more scalable at home. We're going to see combination technologies that are going to enable this. Still some implantable and minimally invasive, but a lot of wearables and non-invasive technologies. Integrative health, where more and more research is coming out, that it's not just your heart, your brain, your spleen, your liver, your immune system, it's all intertwined, and trying to treat one part of your body is not sufficient. There's a lot of variability, and being able to understand that integrative aspect of your body and health is going to lead to better outcomes and better health. More automated and predictive healthcare, especially telehealth, it needs to happen. We need healthcare more accessible to the population, to society. And the part that I think is going to be really interesting to watch out for, and we've done put in effort to make sure that we have this bio component in this meeting, and starting to as we move forward into future years of this conference, is this integration of medtech, bio, and gene-based therapies. So I do believe it's an exciting time. It's going to be a massive inflection point, and we're all here for the ride. So I just want to do a few logistical things, and then we're going to announce the first keynote speaker. This is the 25th anniversary, and it would have not been possible without the amazing executive committee here, shown here in this slide. If you see them, shake their hands and get to know them. They've been critical in making this a success. We have also, the first time this year, we brought in an industry steering committee. We wanted to make sure that we were providing topics that were more relevant for the industry community. And so you're going to see there's a variety of regulatory as well as other topics that are hot topics for companies, such as alternative materials and PFAS alternatives. We cannot run this meeting without the sponsors, so thank you for the premier sponsors listed here, the executive sponsors, associate sponsors, and of course the supporting sponsors. I do want to point out, you have this all on your name card, but please go to the Skiuma room, which is straight behind us. That's where all the sponsors are. Please check out their booths. And we also have the Minnesota room to the corner here, where we have a lot of our innovative centers and the Institute for Engineering Medicine booths there, so you can learn more about them. This is the name tag. Of course, I'm a little bit old-fashioned. Everyone's like, get your QR code, and I don't know where to go, and it's still, I would love something in my hand. So we made sure we didn't lose that. There's in your name tag, there's the program, and you can, it should be separated too, so you can flip it for the next day. And I know you all need the Wi-Fi, so here's the instructions in case, but you're going to be paying attention to the conference speakers, I'm sure. Those who participated in the innovation workshop, thank you. I heard it was a success, and I saw some pictures up on LinkedIn. And I hope we got everybody survived yesterday with the 510K run. I also saw some amazing pictures there, and everyone got their t-shirts and good health exercise. Okay, so with that, we're going to start the morning plenary keynote talks. We're first going to start with Dr. Carlos Guerrero-Chalela, and Dr. Paul Iaizzo is going to introduce our speaker, and then we'll have our second speaker. Thank you.
Well, thanks, Hubert. And we're innovating the program. Dr. Egeland got stuck in traffic due to a car accident, so Carlos is going to go first. And you know, innovation in med device area doesn't happen without the interaction between clinicians and engineers and other scientists. And it's important also to have clinicians that are innovators. And we have a long history of that with C. Walton Lillehei and Earl Bakken. And I met Carlos a number of years ago. He's one of the world leaders in imaging of congenital heart defects, adult congenital. He did his training in Colombia, then in McGill University. He says he's an expert or had expertise in that, but he's really at the top. He's one of the world leaders in this field. He's running a 3D imaging center. He's building an international consortium and helping patients around the world. But the most important thing about Carlos is his passion and his energy. He's one of the most passionate person about helping congenital heart patients and their families. And he has so much energy that if you have an electric car and you need it charged, just have Carlos put his hand on it. And he'll have enough energy to charge any electric vehicle in the parking lots. I mean, he's just dynamic, and I got to know him a number of years ago and call him a good friend now, and always look forward to what he has to say. So with that, Carlos, please.
Okay. Okay, thank you for the invitation. I'm very humble and happy to be here. And thanks, Paul. Many of this haven't been able because of your help, so thank you a lot. So I'm going to talk about how we put together this 3D Plus program in Colombia and how we put it together in a hospital in Colombia. For you, this might be a given, but for us, was like a magical thinking. You know, putting a 3D Plus center in a third world country hospital was a lot of work, yeah. So we are sponsored by the government and a grant from the government. This is the project, so this is my disclosure. Also, we started with good thinking, that there must not be gap between the clinical question and the engineers. And this is not my quote, this is a quote of David Hoganson. And with that in mind, we put together this 3D Plus center in our hospital. So I'm going to talk about the work that we already published and the clinical flow and the workflow. We know all about flows in Colombia. We're the homeland of Shakira, of course. So we know flow, you know. This is Fundación Cardioinfantil. It's in Colombia. It's Colombia, not Colombia. I'm sorry. It's Colombia, yeah. By the way, and it's a beautiful place. Such a beautiful place that I bring the bear hugger to Colombia. So this is Paul showing his guns. And this is my hometown, Cartagena. It's a beautiful city. You must visit. So we started with a little bit of history. The idea was to create a ductal catheter. And so we bought some printers, and the printers, like the elective machine, stopped for a while. You know, just hang out towels for a while. Because it was not only having the printers, but having the group. And it takes a village. And for us, it was a multinational village. And that's what we created, I think. So this is the team. A big shout out to every single one of you. They make it together. We are a mixed team where cardiologists, radiologists, engineers, students come together. Our students keep us, keep us simple, keep us true, and they have all the imagination. They have all the imagination in the world. We created these strategic allies. Again, a big shout out to Paul. He has been very helpful to us. Shai, Mahesh, Masaki. We meet every week. We have collaborators inside the hospital again. Many people working together, many ideas. And we meet every time and joke around and discuss our ideas and collaborate with each other. So we test all of our products. So we test the product from Mahesh. I'm going to show, we test the products from Ryan Moore, from Cincinnati, from Shiva, from Paul here, Javier, and everyone. So we were trying to generate a consortium for 3D Plus technologies, where we can come together, join, and our purpose is to transform technology to make it better in congenital heart disease through 3D Plus technologies. So what do we do in LaCardio and within the 3D Plus Center? Okay, so what we do is basically we transform DICOM images into reports and forms and volumes. We print it out, we put it in VR for pre-procedural planning, basically. And at the end of this, we're going to give to the Ministry of Health of Colombia a policy brief saying if this is cost-effective in Colombia to get it together, to put it together into our healthcare system. Colombia has a very good healthcare system that the governments pay for, kind of your Medicare, but with steroids. We have our people in Colombia get paid 100% of their health by our given to the system. And we do want to go to all Latin America. We're going to give the 3D Plus technologies to all the people in Latin America to help them build more 3D Plus centers, but because we think that is needed in Latin America. And we collaborate in that sense with Mexico, El Salvador, some people in Peru, Ecuador, and other parts. So what do? We put these 3D Plus technologies in 3 points specifically. The first was pre-procedural planning. So we are transversal to all needs of the hospital. Also, we are doing a lot of education of patients and young doctors and engineers with the 3D Plus technologies, because we think it's easier to understand the heart and the other parts of the body if you have a 3D Plus model there. Also, we saw some locative needs of the hospital. We print parts to machines that are needed. So I'm going to talk a little bit about that. I'm going to start with education, because we do think that this sandbox approach helps a lot, because our minds are limited to understanding only matter and space. So if we can give that to the doctors in training, they can learn how to learn. So with that in mind, and the help of course, the Visible Heart Lab, we started creating this CHD library. I do a lot of congenital heart disease. Understanding congenital heart disease is hard. Understanding the heart is hard because it's a moving object. It has a lot of parts. And with that, we started creating these specific models that were actual patients models. So to teach actual defects from and of course, thanks to the help of the Visible Heart Lab, with that we have these hearts that can be assembled to show different parts to recreating an echo. So we can not only show the defect, but how to cut the heart to see the defect. Also, we started playing with some of the apps that the Visible Heart Lab have, and the VR apps that we started creating, and showing how to close a hole, for example, close an ASD, an atrial septal defect, just to teach the young cardiologists how this will be done, or how to put a pulmonary valve in the pulmonary position, or how do you see it, a normal heart and a very complex heart, if you see it on the left side of the screen, in a TE, because these are very complex anatomy, so we need to explain and show. So this helped us a lot, also with the help of our friends from Medifear, Dr. Mahesh here, help us put together a VR app that we can put up to 20 students inside the VR app. And this is me in one of the Thursday sessions. We do 1 hour Thursday session with a VR app, where 7 of my students connect together. In fact, last week or the other week, we connected even here with Minnesota, and I'm teaching there how to see a very complex congenital heart disease, which is called sinus venosus ASD. The important part of this is that we all are in the same room, and I'm teaching with the same model, and they can recreate this model all together. And this has an impact, I think, because people that uses this VR app are now more inclined to use it more, and they feel that this is much better than having a PowerPoint, because understanding the object in the room is more important. And the perception of using the object or understanding the defect is way more didactic with the model in the room, where they can see exactly where the defect is. We have done this many times and in many locations. For example, these are the bald one like me is our echocardiography director. He in chief. So he was explaining the RB through 3D models by echo and the 3D models. In the center is Dr. Sandoval teaching in Peru a very complex heart disease surgery with 3D models, showing exactly to Peruvian doctors how to do this. And the most impressive one is that we started teaching OVGNs to detect congenital heart disease in the wound with this model. So, and the perception of this has been amazing. People and the doctors and students want this more, because they perceive that this is a better approach than the standard. And not only that, they feel that it's way more better to understand the complexity of congenital heart disease and other complex anatomies. So now, beyond education, can we take it to the point of care? So we can take it directly to the OR or to the intervention. So that has been done in the couple of years. So what we did is personalized medicine to improve decision making. So we're gonna give you the SAC model of your heart, so the surgeon can practice the surgery first, or do an intervention first, the interventionalist, and then do it on the patient. So actually he teaches himself a little bit about it. And this is very important to us, because in congenital heart disease or in certain anatomies, you don't have one the same as the other. Meaning you can have a patient that is very different with the same disease to the other. especially in the form of the heart, and that's very complex. Also, if you don't have enough patients like this, and this is your second patient you did, you need to practice the surgery, because again, we have a very complexity, a wide broad of congenital heart disease that maybe this is the third or the fourth surgery of that surgeon. Of course, not the oldest one, but the younger one, yes. So we try to apply it in every single center of our center, basically in orthopedics, in neurosurgery, and in congenital heart disease, because that's the most we do. So this was my first case. This was the way that I got in love with this technology. This was a 75-year-old patient with RB failure. He has this very complex defect, which is sinus venosus defect. But basically, what you see here is that, let me see if I can show. No. Well, you see the line on top? That's a defect. That's a hole in the upper part of the heart. So the way that we see it, if you see it, it's a 2D image. The way that we diagnose it is through catheterization. So it doesn't make any sense in the real world of today, you know. And this patient couldn't get surgery because he had a kidney transplant, and the surgeon said that if he did the surgery, he will, you know, damage the kidney so much that he will lose the kidney. So we were back in the pandemic. We didn't have proctoring, so I convinced the interventionalist that if I printed the model, and there was background on this, we could, you know, tailor-made a stent, as you see there. You know, the gray one is the stent that is unfolded, and the gold one is the stent that is open, that we could close the hole with the stent and reroute the pulmonary venous return without effect. So basically, with that model, with that simulation, we give it to the company and talk about tailor-made. They came back a couple of months later with the stent, and of course, the interventionalist was convinced that it could be close, as you see here, and there was no gradient between the pulmonary arteries and the LA. So the patient got fixed with a 3D model. Moving forward to other patients, these are very complex congenital heart disease. These are apical ASDs. Apical ASDs, to close apical ASDs is a challenge for any surgeon because you don't know where the tip is of the heart. So they can, basically what they did for many years was open the heart, draw a line, and close the hole. With this, now they can open the heart and know where the tip is and separate the ventricles with ease. So in this type of surgeries, as you see here, they printed the model, and they got excellent results. Also, maybe related to what you do every day, we have complex congenital heart disease that needs pacemakers and needs resynchronization therapy. So resynchronization therapy is to make the heart beat, you know, accordingly. But in our congenital heart disease, in many of them, the venous return of the heart is very abnormal. So abnormal that we started printing and modeling and VR this venous return. And now for 7 patients now, we have been printing, and today I told Javier we need to print one, and modeling and VR and showing where is the exact point to enter the venous return of this heart so they can put the turlid. And the EP people on my hospital are very happy because now they only want to do this with a 3D heart. We have a lot of work because now they understand where to put the turlid on those patients. Not only in congenital heart disease, but in cardiac masses. Cardiac masses are a very complex form of cardiovascular disease. These cardiac masses they might be around the heart, or they can be inside the heart, and they can interfere with critical part of the heart. In this case, for example, this is called a mistletoe sign. Basically, meaning I didn't know, I'm Colombian, I don't have a mistletoe, so I didn't know. So I had to go and find it out. For you, you know, I understand what a mistletoe, but basically these masses surrounds the coronary artery. So to take it out, you need to understand the relationship with the great vessels. So we started printing these masses so the surgeon can practice the surgery and put back the heart inside. Basically, it's like an auto transplant. So they took the heart, they shaved the mass, and they put it back again. So they needed to practice this because this is, one in a million. And with this, they find it that these technologies can help them understand the relationships and do better the surgery. More importantly is that Colombia is a white country. It's not as big as the States, but we are very disaggregated, and people that are from Latin America here will understand what I mean. So basically, we have great teams in a big city, and we have the best city in another city, and that can be 100 kilometers apart. And patient can have to go back and forward in burro or in a canoe. I'm not joking. Patient have to go from point A to point B basically in the back of a burro or a canoe. And the surgical team only gets a city. Of course, the surgical team say, I cannot open this, I don't understand. And the patient has to come back and forward. So what we have found out with these technologies, actually, is that if we give the model and a report to the surgeon group with that beautiful image that they took, they could understand better and probably serve better the patient in the hospital. So and they don't need to transfer to Fundación Cardíaca Infantil. They just do it back home and the patient is happy. So we have done this with many complex patients and many groups, and of course, we found that this connects and bridges the gap. So it's not only beautiful model, but bridging the gap in our system. Many other things that we have done. So I have to talk for 40 minutes. So normally I talk for 20. So I need to put a lot of cases there. This is one of the most inspiring one that we have. If you have read Gabriel Garcia Marquez and 100 Years of Solitude, if you haven't read it, read it, because we talk about yellow butterflies. So yellow butterflies appeared in the dreams of the character. So we started printing this very complex congenital heart disease, which is called anomalous coronary artery. Anomalous coronary artery is 1 in 1 million. So you don't see one similar to each other. But to repair this anomalous coronary, because they pass in front of the aorta, is quite complex. You need to reimplant it. So we started printing these models to show the surgeon. The surgeon is an expert, of course. I cannot offend a surgeon. Hope not. Yeah, I'm gonna get. But he needed to understand if he needed to do one surgery or the other, with these patients. So we started printing them and converting this 2D image that is difficult to understand to a surgeon because he's seeing the heart beating up, with virtual models and 3D printed models. So we ran out of yellow, so the yellow butterflies converted into blue butterflies because we ran out of yellow ink. And now we think that this can help better predict outcomes in those patients. We want to correlate this with 3D plus market. And we are started simulating new surgical technique that serve better the decompression of the pulmonary, of the coronary artery. So I keep you posted because our surgeon is going to be very inventive trying to generate new techniques to repair these patients. And by the way, this is the second cause of death in young athletes. So if we repair well, the athletes can come back to sports, not to competitive sport, but to sports. We don't only do congenital, we also do a lot of orthopedics. This is, I'm a cardiologist, but I just find it amazing. They generated these guides so they can practice the surgery, so they can have this this spinal cord strained in these severe scoliosis cases. We have a lot of scoliosis cases. Also, they have print out the trachea, because tracheomalacia is very common in congenital heart disease because of long intubation and some others. So they have also generated techniques of surgery with this and teach this to other doctors. And the acceptance have been amazing. The acceptance have been amazing. We have been, of course, using it more in congenital and in cardiovascular disease, but once We started with congenital, the orthopedic surgeon wanted, the neurosurgery wanted, the general surgery wanted, and transplant wanted. And what we have evaluated is the user satisfaction. So the user satisfaction of this model have been amazing. Of course, the old surgeons say, I knew what to do, but still they want it. But the youngsters, the more young surgeons, that they are not that exposed to that complex anatomy, they are very happy to have every time that. We are printing a little less. Our older surgeon wants more printouts to practice the surgery. Our youngsters now are using this technology. And this is a big shout out to BR3S. We are the beta site of this technology. Basically, what Ryan Moore and David Molares developed is a suite where you can simulate any type of surgery. And this is him teaching us how to put a harmony valve in the pulmonary position for a patient. Harmony valves are a very precise type of valve that you can put on RBOTs. As we didn't have billing codes as here in North America, we had to generate our own billing codes based on our time and use of the printout. And with these billing codes that we generated, now we are able to give it to the hospital in such a price that we get a little bit reimbursed by the insurance, so we can sustain the practice. So basically we mapped out how much it cost, how much it was Javier's, Camila's, myself, sitting down. And because the printout is not only the cost of the print, it's our time computed there. So now we understand if the technology, for example, is a polyjet and the amount of detail is too much, how much it costs. These costs are updated, but at least we don't bill for it exactly, but we do tell the insurance, we do tell the how much it costs, because we want to be pure in the part of saying it costs X. So later, if the technology is reimbursed, we are reimbursed by it and sustain the practice. So, and this is a good exercise to understand if it saves money. So what we have done a little bit of a pilot is what happens if now you have the 3D Plus technology. So in many patients, what happened is that they didn't have, they have a surgery and they bail out. And then they print out the model, of course, and they did the surgery. So we compare that pre and post. And what we found out is that first was a reduction in OR time by almost 347 minutes. So time is money. So we save time. So having the model in complex cases might save time and money. Also, it reduced the hospital stay. So again, more turnover for the hospital and more precision to the patient and better recovery. So we do think now that the 3D Plus technology serves a specific type of patients that are derived from the MDM, and it helps communicating the companies because we don't have a given for all this technology as you have. We have to tailor-make most of it, and it's specific to the surgical team and the intervention. So now we understand where it fits in our patient pathway of care. So we also have taken to innovation. Again, I told you it started with a ductal catheter. Now the ductal catheter is patented, and a big shout out to Dr. Briceño and you guys that have been patenting this, and we think that they're gonna start developing in Colombia. We also start manufacturing in-house locative solutions because it not only helps to improve surgery, but also to improve locative solution because we don't have, we cannot replace a machine every time that it fixes. We don't have the budget, by the way. So we're starting solutions that help the hospital and save money. Now, where are we taking this? Beyond the models, beyond this. So I think we are paving the way in our center to the digital twin. So I'm going to talk about something that is in our hearts, which is congenital heart disease. Basically, many of our patients have problems in the right ventricular outflow tract. These are typically patients called tetraloiofalo. You might know this because One of the first surgery of tetralogy of Fallot was done here in Minnesota. So basically in tetralogy of Fallot, what you have is obstruction of the outflow tract, a BSD, and a blue baby. To relieve the outflow tract, what you need to do is close the BSD, and as you see here, generate a relief of the outflow tract that for many years was done by a patch. And if not, you need to create a conduit from the RB to the PA. And this is important because it needs reintervention later because you cut the outflow tract and then you cut the valve. And this is not only for congenital heart disease, but for many other patients that need a pulmonary valve. So this is one of our teachings here, how to explain what is a tetralogy of Fallot through BR, and just to point out that BR is incredible to explaining the defects that tetralogy of Fallot have. And this is important in our country because it's the main moderate disease in our country. We have up to 300 or 400 babies born with this difficulty. And the way that we see it now, of course, is with echo. So, of course, you're familiar with echo. So, as you see here, the RB is severely dilated. We have this severe pulmonary valve regurgitation, and also we use these images, which are my passion, MRI, to estimate the severity of the regurgitation, of the pulmonary valve regurgitation, and the dilation of the heart. So what we do is we put together these many images to diagnose the disease condition and understand what to put in there. So what we want now is enhance that part. And long-term survival of this patient is dismal because they have 10%, they have 10 times more risk of death than the rest of the population. And the risk of death is basically given because of pulmonary regurgitation. Pulmonary regurgitation dilates the heart, gives RB failure, and leads to premortal death. So replacing the valve in this patient is very important. And for many years, the only thing that we have to do to intervene this patient were do another surgery, and then another surgery, and then another surgery. That didn't fit to us because, if you get a surgery when you were 6 months old, and then at 14 years of age, another surgery, and then at 30 another, and then at 40 another, it didn't make sense. So what it makes sense is that if we could put a valve inside of it, a percutaneous valve. But the problem was that you have this very severe dilated outflow tracts that expand, and they're very pulsatile in the flow. So as I said, we needed to create a landing zone, and many people in this world have developed valves. One of them is Harmony, but you need to go to all this evaluation. Basically, you need to do a cath, a CT, an echo, and understand what valve to put in. So basically what you do first is an echo, then you do a CT, then you measure with 3D, then you remeasure with 3D, and then you put a balloon inside of it, see if it fits, see it doesn't compress the coronary artery, so it's many steps for the patient. So what we wanted to do actually is see if we can make it better with this. So what Camilo started doing is doing these very beautiful outflow tracks based on only one image, which is CMR, because we use it every day. And he put it very well together to actually make it in seconds. So we can now make forms of outflow tracks in seconds. And we can measure inside those outflow tracks and measure those parts that we think is the fitting of the valve. And actually we can make our own fitting to understand which valve to put in, that both in systole and diastole. And with the valve that we have in Colombia, understand which type of valve to ask the manufacturer to give it to us. Also, we can generate these images so we can simulate the angio and understand where the coronary artery is related to the pulmonary artery, because if we put a valve there and compress the coronary artery. Also started experimented with tissue to understand what is the properties of tissue and understand the flexibility of tissue to understand this that is called the sizing balloon. Basically, to put a valve inside for many years, we need to put a sizing balloon to understand the size. And of course, we always take it to the patient, and this is our proctors showing with the 3D model how to put a valve, and now we are able to put more valves in more patients with less cost to the system. And with that in mind, as we had a lot of RBOTs, we started thinking, can we make native outflow track evaluation? So we started a statistical shape analysis to understand what was our patient's broad scenario. Because as I said, one patient is not the same as the other. This won a lot of prizes, specifically the Paul Dudley Award. And with this nodal displacement in mind, what we did is, what Camilo did actually, is to understand the internal deformation evaluated in the circumflation deformation, because as soon as you put a stent there, what it compressed is the circumflation deformation. But we also needed to understand what was the internal pressure and the tissue properties. So the tissue property, we already have it. And what we generated is exactly 700 finite element models. We reconcile the pressure inside the artery at the moment of the cardiac MRI. So basically, we're trying to get a cardiac MRI as a one-stop shop for simulation. We also validated with flows to understand what is the behavior of flows and the behavior of the deformation. And these are our results. As you see here, if I can zoom in, you can see that patients have different forms and different shapes regarding the pressure inside. And also we found out that it's a linear form of pressure. And this is good because we are giving it to the world. Camilo is giving it to the world. The group is giving it to the world. So you can use it, play with it, and the end game will be that you use this data set to generate more information so you can fit valve there. We are not stopping there. We want to do more planning and more simulation. And this is one of those simulations with the stent inside. And of course, we are now creating models with flow and fitting of valves. So in conclusion, we have established a 3D Plus center in our home. We want to develop a specific patient model to enhance care and innovation and precision medicine. We want to create a sandbox environment for education. And we have created a simple validated framework that supports clinical research, device development, and application in shape moldings. And of course, we have a simple solution for third world hospital settings. Our future direction will be to do the policy brief for Colombia Ministry of Health and evaluate the cost effectiveness and develop best practice for Latin America. Thank you. This is my content.
Thank you, Carlos. I think we have time for maybe one or two questions. Do we have one or two questions from the audience? All right. Okay, go ahead.
I'll just speak loudly. Thank you. That's very impressive. Can you all hear me? This is yours. The recording. Yeah. Okay. Maybe I'll just ask here. That was a very impressive presentation and the 3D models. And you're at the stage now where you're setting the foundation for this image approach. Is there capabilities for the future of Colombia to have telesurgery opportunities, considering you showed how they have to get to these different areas? Or is that still something financially that is a tough, or can you have a hybrid where there's surgeons locally who are skilled, but maybe you have that expertise that comes in there? That'd be very interesting to hear.
The problem with the surgeries reimbursement in Colombia, we have Da Vinci's, but it doesn't get paid by the insurance. So the cost to have a Da Vinci, for example, I'm saying, and have this telesurgery is too much for the hospital because it basically is difficult to sustain. So only certain private insurance pay for the Da Vinci, so it's not widely available. Also, it's training in this type of surgery is complicated, although we have it. We use it mainly in Colombia, as I understand, but I could be wrong because it's not my field, in prostate cancer surgery, because it reduces quite a lot the risk of infection there because of and it's the only, as I know, maybe I'm wrong again, because it's not my field, it's the only one reimbursed. But yes, what we want is that we can give the technology to people so they can do it better in the region, not to basically to decentralize health, and they understand better and they can do it better in the region, because we need to prepare these surgeons to the region. If not, they're gonna keep coming to the center, and it's not fair to the patient.
Thank you very much. I really like your presentation, and in regards to the teaching with 3D models in order to teach physicians, medical residents how to improve their cardiac training. I'm curious if you've also dabbled in the world of extended or mixed reality technologies so that you can also interact with the heart in a real setting, but also extend it to a VR setting so that they can see the heart pumping, and in that way they can understand it better and have a better understanding so that they can further reduce the length of stay and the OR time. Have you dabbled in those?
So yes, we use VR all the time, as I explained. Now we are shifting more into the VR AR aspect of it, because again, it's way cheaper first, and then you can play with it. The beating heart, we only have one beating heart that is given by the Visible Heart Lab. We still cannot, we don't have, actually, we have static hearts. So that has been a challenge to animate all the congenital hearts. We have some 4Ds, but to segment the 4D has been also very complicated, but I think we're getting there. Specifically, I think Maysphere XR and BR3S from Ryan and Mahesh, respectively, they are developing now these hearts, or trying to segment these models in a 4D form. I was talking just to Javier, meaning we're craving to have one sequence that is called the 4D music, that is based on feromoxetol for MRI, and the temporal and spatial resolution of this image is great for 3D modeling. So we hope to have this, to start playing with it and have that exactly here.
Yeah. Well, thank you with that presentation so much, Dr. Carlos. So with that wonderful talk, we're going to have our second keynote speaker, and that'll be Dr. Ryan Egeland, who is the Chief Medical Officer and Senior Vice President of Solventum. Dr. Ryan Egeland is also the, as Chief Medical Officer of Solventum, formerly 3M Healthcare. Appointed in 2024, he serves as a pivotal leader for the independent medical technology at Solventum, bridging the gap between clinical practice, scientific innovation, and commercial strategy. Before then, he was serving as the CEO of Crossfire Medical and was previously the Chief Medical Officer and Head of Strategic Ventures for Cardiovascular Systems. His intensive industry background also includes leadership in business development, licensing, medical and scientific affairs, and product marketing at Medtronic, Covidien, and EV3. Dr. Egeland did his training at Harvard Medical School for his MD. He also holds a PhD in biochemistry and engineering, as well as an MBA from the University of Oxford, where he was also a Rhodes Scholar. He did his clinical training in plastic and reconstructive surgery at Northwestern Hospital, I started to stalk him on the internet because we've gotten to know each other over the years, and I find out more and more interesting aspects about you. He was playing competitive sports, college football at Colorado College, and I didn't know this about you, but he had received the NCCA Today's Top 8 Award, which at the time, now it's 10, but back then was only given to 8 student athletes in the entire country across all sports and divisions. And I think what's interesting about Dr. Egeland's career is that he has a very unique journey, which he's going to integrate into his talk today, where he spanned medicine and science and engineering and business, and also worked across sectors where he was in, academia, medicine, surgery, and also industry. But what's also interesting is he's able then to combine all that unique experience to bring that to Solventum, where Solventum is actually, as many of you know, in a very unique and novel stage where they're kind of like a large startup company, and they have a lot of opportunities to expand and innovate. And so I do think what you're going to hear today is a reflection of his competitive and innovative as well as team-working capabilities to bring this large team together to push innovation through Solventum. So we're very excited to have you give the keynote this morning, Dr. Egeland, and the stage is yours.
Well, I'm going to try to integrate, although that's going to be pretty difficult. I have to open saying that it all started, that crazy list of activities that Dr. Lim just described started across the street. And it was in the basement, I don't even know if the building's there anymore now, of Deal Hall. It was just a very kind laboratory scientist by the name of Mike Herron, who, when I was in junior high, actually invited me to just come and learn about science. I did not have any scientific parents. I didn't have any interest or knowledge, really, of medicine at the time. But then that led to everything that kind of followed. So I'm going to try to share with you, I can't cover all of that, but I'm going to take a little bit of a different tact in my talk and share a little bit about my path, which, by the way, I have to, it's interesting. I used to park actually right where that column is before this was built. This was a parking lot. And I used to go into the Phillips Wagenstein building first, started out in the Department of Hematology, and then during college I would drive down here and spend my summers doing research in the Department of Ophthalmology. So I had very, very kind mentors, and I owe literally everything to what they did on their own accord. So if I can do the justice of their kindness and to this institution, I hope to do that. So with that, I have to say also I wouldn't be in this role as a chief medical officer if it didn't start really with my training as a scientist. So when I come and sit in this building, it actually feels like home. I feel more like a scientist, clinician, business person. But my job full time now, of course, is at Solventum, and so I'm going to try to introduce this group a little bit to Solventum. I actually knew very little about 3M Healthcare, and I've lived, in the Twin Cities for 10 years. So I'm going to introduce a little bit about that, not making an advertisement. I'm also going to talk about really the profound reasons that we're here. And I love Carlos's talk too, because he touched not just on the technology, but on these issues of education. Physicians, how can you get the best technology in the world? If they can't use it, it's not a product. It certainly won't help people. The other aspect that he brought up was something that I didn't really know anything about those years ago, which is the finances, the money, how businesses work, and it was not by any intent or conscious effort of my own that I ended up going down that path. So I'm going to share a little bit, and hopefully you can catch some things from it. And again, it's going to be a very, very different talk, but I hope you find it valuable. And in part, I want to go through a whirlwind of things so that we can understand how innovation happens. Innovation isn't invention. Innovation is building something simply that other people can use. And a business is nothing more complicated than a paying customer, right? So it gets very complicated, but I think that's really the essence. So I wanted to just talk a little bit. After I left college, I was hell-bent on becoming an academic physician scientist. That's what I was going to do. And due to no intentional effort of my own, I ended up getting a scholarship to go to Oxford. Never been out of the country. This was a scholarship that kind of actually, to be honest with you, I was frustrated because I was so focused on academic medicine that I didn't want any distraction. But just, this was a scholarship, you're supposed to kind of do something different, so I figured out what's the most opposite thing of academic medicine? Economics. But a classmate talked me into joining this new business school, and this is actually the business school. This building here is called the Radcliffe Infirmary. So I'll try to, there's some really profound connections here. But this was a detour that changed really the course of my life, and I think brought me an entirely new domain that I didn't even know existed, and probably a domain that many of you may or may not appreciate or be fearful of, but I'm gonna dive into that a little bit. So what happened is, this was the business school. It had just opened. It was actually a 300-year-old hospital of all things, so I tried to leave academic medicine, do business, and end up in a hospital in England. But in the basement of this hospital is where we had the business school classes. So this is my first week in business school. I'm just wandering around this old building. It was absolutely decrepit, okay? It was a rundown hospital. There's kind of these sickly patients coming in and out. It was the NHS. It was kind of half dead. They were about to retire it. It's the cheapest open space for business school, which had just founded. So I was wandering down the hallways and just exploring, and at the end of this very dark hallway with broken fluorescent lights and kind of medical, boxes around, nobody there, vacant, I see a brick wall, and just kind of curious, look at the brick wall, and saw, this is a modern picture of it, but this is what I saw in this basically vacant hallway that could have been out of a thriller movie. What I actually saw was a worn down wooden plaque, and no attention to it. This is where the very first human study on penicillin was conducted, right behind this room that I was in business school. And I'd never heard of this. You think, okay, well, penicillin, what the heck does that have to do with Oxford? I thought, first of all, and why was it in a hospital? I thought it was a guy that, we know the story. It was, a scientist in a lab that saw a petri dish and discovered the biological mechanism of the antimicrobial nature of penicillin. And he won the Nobel Prize, and the rest was history. Well, I couldn't help but be blown away by this coincidence of seeing this unkept plaque that was just sort of forgotten. So I actually was thinking to myself, maybe the history isn't exactly as we thought. And I discovered, lo and behold, he did his, Alexander Fleming published his work, and it went into a publication and sat there for almost a decade. Nobody read it, wasn't profound. It actually turned out a graduate student, and many of you are graduate students. I know what that was like in your first, few months. You're trying to figure out what is my thesis going to be, so you sometimes have a lot of spare time. Anyway, I don't know the exact history isn't cataloged, but he came across this publication. And they were working in a hospital. His advisor was Dr. Flory, a very famous academic. And what happened is this graduate student just read this publication from Alexander Fleming completely randomly. Now, he was a biochemistry graduate student. He wasn't a clinician. He wasn't a biologist. He was looking for something to do. Anyway, he bumps into his mentor and starts having a discussion about this. And lo and behold, long discussion, they come up with the idea to not just put bacteria, you can't apply bacteria to a patient, of course, you have to purify it. Well, he was a chemist who was in the right place at the right time, and he did his work on purifying the active agent within the mold. And his physician advisor was senior enough that he could get the funds, and they did a quick clinical study and discovered that it was clinically efficacious about 8 years after the original basic scientific discovery. And of course, then it went into clinical trials, right, and became a success, and they got publications. No, they actually ran out of supply. So this is what they used. They used urinals and bedpans to culture the penicillin mold. They couldn't get funding. They were chastised for consuming clinical space because what are you doing this crazy experiment? You know, we need to be treating patients. I'm sure many of you are familiar with that. So this is what they did. They cultured it and were successful. Not successful enough, though, to get any money, and not successful to get any interest from industry. And actually not successful enough to really make a clinical impact, because they didn't have enough. So you've got a basic scientist, you've got a clinician, and you've got an engineer, a chemist. Still wasn't enough. So, well, you get venture funding and off to the races. Not so much. They couldn't get any money, and so they scaled it up. Industrial manufacturing, they used milk cans. This was the next phase of their scale-up procedure. Doing it themselves. So what did they need to do? Well, you know, you need to scale up, you need to have a partnership with industry, right? Well, this is penicillin. It's the most modern miracle you can imagine, right? It's arguably the most monumental clinical trial in the last several hundred years, if not all of human history. And they couldn't get any interest from the UK companies. So they flew to the United States, knocked on a lot of doors, got a lot of invitations not answered, bumped into a government official who, for other reasons, was interested and had some money because they were going to World War II. Now, that led to some specific exemptions on antitrust, which was required to then get a pharmaceutical partner to scale up, and this is the early scale-up. That took a lot of time. It didn't just happen. So now you've got basic science, clinical practice, engineering, and government, and industry. And that's what it took. So we all know about penicillin, but it wasn't a path from A to B to C. It was almost like B to A to D to Y, and that's how it happened. So anyway, I tell you that story because that was really important to my experience going into business, bumping into this, and then discovering, hey, maybe it's not quite as simple as we think it might be. I'm going to transition then to, and again, I'm going to be bouncing around, guys, because I think we want to talk about all of these domains which are necessary, and I'll tie it back together in what I'm doing in Solventum. I want to stay focused on the patient. The patient died. Even though the original research was success, and the popular myth is that he died of a rose thorn scratch. What he actually died of is something much more mundane than that. As a surgeon, I saw this all the time. Some things are not that complicated. Okay, he had a wound. It was not a deadly wound. There was a bombing raid, and he got a wound that didn't heal, and it got infected. A simple wound. We all know what wounds are. That's what killed him. So I'm going to tie back to what I'm doing at Solventum in a moment. This brings me now to kind of the second trip. So I'm in Oxford, finishing up my business degree, which is 1 year. I have a year left of scholarship, and I wanted to do engineering. I liked engineering, I liked basic science, and plus they're easier to get your research done because you don't have to wait for rats and things to develop. So I applied to an engineering master's degree and got a call from this guy. He doesn't take students, and he's at the Department of Biochemistry, and I'm wondering, what is this? Well, this guy's name is Ed Southern. He invented DNA fingerprinting. He invented something called the Southern blot. Then he invented something called DNA microarrays. And then he was one of 4 people to found the Human Genome Project. And he was an engineer. He didn't care about biochemistry, believe me. He was widgets and building things and putting things together. His career started, this is the, as you know, a famous biochemist. When you hear Ed Southern, okay, well, famous biochemist, right? He got his idea by this. He was employed to make money by a grocery or food supplier in the UK. They were looking to increase the shelf life of tomatoes by using irradiation. What in the hell does that have to do with DNA fingerprinting? Well, he was the first to bring radionucleotides into markers. He could see that you can use radiography to detect chemistry and then separate it. Came up with the gel, came up with the radiology. Knew a little bit about biology, but not much. I didn't either, but I was in the Department of Biochemistry. So again, the point here is engineering enabled basic science. That's not the way we think. We think basic science leads to engineering things, and then it leads to an application, and then it leads to a business. No. One of the most pivotal things in the history of basically biochemistry and genetics was actually founded by an engineer. So that's point number 2, a little contrarian. I'm going to tie in, I don't know if anybody studies history, but this is really profound when I discovered, one of the things when you're in England, you kind of get into history and you're just kind of, 10 miles from all of these historical events. So this is about 30 miles from me. I came to discover this. I always had aspirations, really profound respect for basic scientists, somebody that could get a publication in Science Nature. And so I always assumed the mantra was accurate. Basic science leads to then fundamental, basic theory leads to engineering application and then leads to an invention, and then you lead to a business. This is a picture of the coal pits in England. And this is actually the way that you think about this is you would think, well, what does that have to do with science? Well, let me make the connection. The picture on the bottom right is one of these pits, and what they were trying to, these are just simple poor people trying to dig out pits in the ground. And the problem was that water kept coming into the ground and they had to pump it out. And it wasn't easy to pump it out, so they built these things. It was called the Newcomen steam engine. But the Newcomen steam engine wasn't very efficient. So these guys are poor. They're trying to get the coal out, burn it so that they can run the pumps to pump the water out so they can get more coal. It's not an easy business. And if they couldn't get the engines to be sufficiently efficient, they'd go bankrupt. So that was the problem they were trying to solve, and you know what it led to? Second law of thermodynamics, after the pumps were thought through. That isn't the way I think of it. I thought that you use these basic fundamental theories and then apply them. No, that's not what happened. So my point here is in solving practical problems, some of the most that's one of the most fundamental physical insights in all of chemistry and physics is thermodynamics, and it came, in essence, from the bottom of a coal pit, trying to solve practical matters. So again, the connection here is things are not always as linear as we think. I'll tell you back then to the clinical side of my career. So following Oxford, I went to train in surgery, and these are some of my mentors at Harvard. The guy on the right is Elof Eriksson. He did actually the first human face transplant. It was miraculous. It got a lot of press at the time. Didn't treat a lot of patients, though. Got a lot of publication. Didn't really affect many patients. He got, famous for it. The guy on the left is Dennis Orgel. He was the first real, true physician scientist that I met. And first circle, randomly, this had nothing to do with my current job, it's just a connection. He was one of the first people to elucidate the mechanism of action for how this particular device called a wound vac creates increased healing. He used finite element analysis. He had a partnership with some scientists at MIT. I was his medical student when he was doing all this. So there's some very interesting connections here. The problem again, though, is a lot of this work, I went into residency, I didn't like it. Not because I didn't like taking care of patients, I loved it. What I hated, kind of being an engineer maybe being impatient, was the inefficiency. You know, the limitation of what I could do with my own two hands was pretty profound when you're thinking about building devices. All physicians, all surgeons, and you know, we can only make a difference for one patient at a time. As a surgeon, you know, there's only so many hours in the OR. There's only so much real estate you can cover on rounds. So it's profoundly frustrating, it was for me personally, to see all these sick patients and not be able to do anything. It was the limitations in time. It really was very, very disruptive, I think, to my own self-worth, really. And that leads to my third counterfactual. We often think that physicians, surgeons make a huge difference. Cardiologists, as we heard, make all the difference in society. And I think as we heard from Carlos, what he's working on is not just the technology. He's trying to figure out ways, and I loved it, how can we enhance the impact of that by training? The point is this: you can't get scalability as a surgeon or as an individual physician. They can't do it. You've got to find ways to get that scalable. Sounds familiar in concepts of engineering. So the massive societal impact doesn't come from surgeons. It has to be a partnership with industry. Just a quick point on here. For those of you that work with surgeons or physicians, they all do it their way. They're artisans, right? This is a picture of the artisans in the medieval time, okay? Everybody does it different, and they all do it the best, including myself. That's what we all say, right? But they don't. What they hate is standardization. But in the medieval period, there was a lot of poverty, because when you're building an individual screw and a bolt, custom each time, it's kind of hard to put pieces together. So this is something called the manufactory. This is a pivotal, probably the most important building in the history of elimination of poverty in mankind, is this building. And the reason is, that's where they invented the manufacturing line. It wasn't Model T. So when that happened, profound levels of productivity happened. Now, they didn't like it. It's not as artistic as an artisan, but you can get unbelievable amounts of volume by reproducibility. That can't just take that for granted. So the point is this: in medicine, we don't really like scalability as practitioners. And that's a problem because it increases costs. Something very similar to maybe engineer mind might have. So finally, then, I'm going to move into where I am now. That frustration and then a long career path, as Dr. Lim described, kind of in various companies, led me to Solventum in the medical device industry, where I spent the last 20 years in startups, mid-sized companies, kind of the full gamut, including cardiovascular, which never was my competency. I kind of had to wing it and pretend like I knew cardiovascular medicine, which I didn't. But now I'm home. I'm at Solventum, which is really a company that's focusing on some very important things. But you may not know the name Solventum. Everybody knows 3M. Company was actually, it's a separate company now. It's only a company that's 2 years old, but it's got all the same products. So if you know, if you walk over to the dentistry school here, you'll see these products everywhere. Everybody knows these products. ClinPro is one. Fluoride treatment. If your kids go to a dentist, they're getting this product. You don't know Solventum and probably don't know 3M Healthcare, but that's part of our business. I don't spend a lot of time on dentistry yet. We've also got a brand called Tegaderm. If you go to any hospital in this country, there will be Tegaderm. I guarantee almost all of you or somebody in your family has had this product on your body. It's been around for many, many years. We're advancing it now. This is not rocket science, but adding an antimicrobial to Tegaderm is a non-trivial issue when you're trying to produce millions of these per month. One little hiccup in the line, one little quality issue, not only potentially hurt the patient, but you lose the whole business when you've got that scalability. So there's different problems, I would say, in industry, and I wanted to kind of share that. This is the product that I spent a lot of time. It's called the wound vac. It's not complicated on the surface. However, the interesting thing is it's the most important innovation in wound care since the wet to dry gauze dressing in 1965. There's not a lot of innovation in this space. So I was kind of always told, you know, if you're going to go into a space that's really hot, you got a lot of competition. There's not a lot of competition in terms of technical innovation in this field, candidly, and this is my field, right? So there's a big need. You wonder why. Why is that? You know, there's people investing money. It seems odd, but I want to talk a little bit about maybe why that is. Now, we are doing some other things. Like I told you, I'm not going to get into the deep science. We can talk about more of this. We acquired a company called Acera Surgical. This is it's called a cellular acellular matrix product. Basically, it's like a skin substitute that mimics the collagen fibers. This one happens to be a polymer. It's synthetic. So we're going to integrate. This is in particular for patients that need additional tissue and you can't use a skin graft. This is an area that's been under research. I mean, this stuff was very interesting and exciting 25 years ago, right? But to get it to a clinical product is not trivial. So I want to talk a little bit, well, why isn't there innovation? I can't come up and talk like Carlos did about 3D imaging. There's not really that much there that's whiz-bang. But here's the problem. Ultimately, we're treating wounds. This is the kind of wound healing pathway that everybody's probably known about. It's not complicated, but what's complicated is when it goes wrong. And we've got a real serious medical issue. Just to give you some statistics and compare it to the other fields that we're in, the 5-year mortality rate for a patient with a foot ulcer that comes from diabetes is 30%. If you got diabetes and you end up with a little ulcer and you think it's not a big deal, that's as bad as most cancers. In fact, it is as bad as most cancers. The rate of death for a patient with a wound is on par with the top 5 most common cancers. A little wound. I didn't know that. This is a really profound problem. It's not talked about. Why is that? Here's the other thing that's really interesting. Wound healing research receives only, guess what, 0.1% of all NIH funding. Okay, well, who cares about wounds? Somebody must have it right. You know, maybe there's no problem there. Well, let's dig into that. You know what it is? You know why there isn't attention? It isn't the science. It's not the clinical need. It's an accounting oversight. The reason that none of the money goes into these particular patients is something little nuanced little trick called the DRG system. It's the way that the Medicare coverage pays hospital. And just because of the way they set it up, there isn't a specific diagnosis code for wounds. So when a patient goes into the hospital, they get a diagnosis of diabetes, they get a diagnosis of an infection, CHF, sepsis. They don't get a diagnosis of wounds, but they have wounds. In fact, a third of all diabetic patients, a third of all spending on diabetes is in wounds. Never knew that. That's what we're working on in Solventum, and I'll talk a little bit more. Here's some other stats that are really profound, and I've spent actually kind of in my cardiovascular world a lot of time on this. The cost of treating a single advanced stage patient with an ulcer from a diabetic foot ulcer costs $50,000. They account for 25% of all healthcare costs for diabetes. That's on the headlines of everything. Diabetes, it isn't just heart disease. It's not just peripheral vascular disease. It's also wounds. So this goes to this important point of unmet medical need. And I wanted to bring all of that because it brings us back to what I experienced as a clinician. It's about the patient. So when a patient has these wounds, not only does it consume costs, it consumes their entire family. Because if many of you have had elderly or relatives with wounds, you have to take care of the wound. Patients and families that don't have resources lose their jobs because they can't work. So a little tiny diabetic foot ulcer not only creates all those medical problems, it brings down the whole family. It's absolutely abysmal. So I'm very passionate about that. I'm happy to be at Solventum. To bring this a little bit more broadly, we joined a group and we're supporting something called the Wound Care collaborative community. And this is a group that's specifically very novel. It's a connection of industry people, scientists, clinicians, regulators, payers, and students. And we're going to face this in a cross-functional way. The reason I went through all that crazy stuff about the laboratory and penicillin, this is what's going to take to solve the problem. So I'm going to bring that back now kind of quickly to Solventum. People kind of ask me a lot, how do companies know? How do you know what you're into? I was talking to Hubert, you know, what are you guys interested in? It's not as simple as just technology. And so our name is, I think, important. This really is what we're trying to do. We're trying to solve problems with momentum and do it with speed. That's our goal. It's really that simple. Of course, we're a business. We want to make profits. But I can tell you, no business makes any money if they don't serve some sort of a customer need, first and foremost. Just to give you a quick snap, this is a big company. We've got 22,000 people. It does feel like a startup, and it's right up here in Egeland. It's our headquarters. So we're going to build partnerships, hopefully, and continue to bring people into the company. I personally want to do that and also learn from this group. I don't think we've done enough of that. We've also covered the entire globe. Unlike most companies, because these products have been around and they're generally low cost, there's not really a country in the world where we don't have presence. That's unlike many other companies. We've got manufacturing facilities that take us almost a zip code in South Dakota. Okay, there's unbelievable scale when you talk about the manufacturing I said. This is a company that I've never seen like that. Unbelievable ways. If there's an idea or an invention that needs to be manufactured, you spit it into this little manufacturer and you get 1 million products next week. It's amazing. And again, as I said, global footprint. So I'm gonna kind of just, you know, I can't go into all of the intricacies of what it's like to be in a company, but you know what it really is in the bottom line? Yes, there's a lot of calculations on finances and resources and HR and all that. But in the end, this is what our CEO talks about, and this is what we intend to do. It's to enable better, smarter, safer healthcare to improve lives. That's what all of us are talking about here today. Sometimes we forget that. It's not about the technology. It's not about the money. It's not about the clinical trials. It's not about the ability to be the best surgeon. Can we improve lives? That's the most important thing, and we lose that. I've lost that. It's very easy to forget that. The patient I showed you in penicillin, whoever thought about him? He died. We forget about the patients. We're trying to consciously not do that and specifically focus on something called unmet medical need. So this is, I'm going to bring you just real quick into the kind of the inside shop talking in companies. You know, they ask, how do you buy a company? How do you decide you're going to buy a company? How do you decide what you're going to invest in? This is kind of a short little framework. I can't cover it all, but it all starts with the unmet medical need. If there's no medical need, we don't have any interest. And medical need could mean money. It could be an economic problem. It could be pain, it could be life and death, anything. And then we have to see how big is that problem. That's what we call the brain. Is there an ability to make a difference? Sometimes there is. Sometimes there's things that really, like the face transplant. Great technology, not a big market, not interested. It's very important to understand that. Barriers, then even if we had a solution, can we fix them? You know, it's not good to have a technology. I've seen a lot of technologies that are miraculous in the operating room, but nobody knows how to use them except 2 or 3 docs to get 3 weeks of training. That doesn't work. And then finally, solutions, because there's something that we can solve for here. How are we doing on time? Okay. Okay. So quick thing, I'm going to just, I've written some papers and you know, I kind of still have some aspirations to pretend to be a little bit in academia. So I published a paper 10 years ago when I was at Medtronic, really for surgeon innovators, to talk about this mysterious concept of money in medicine. And we did a lot of interviews. You know, one of the things you do as a scientist, you just start asking questions. So we asked a lot of hospital CFOs, what do you need? And I think the one takeaway is this. This is where innovators, including myself, lose track all the time. You can't just serve the physician, because nowadays every single physician has to get the authority of the purchasing group or the hospital CFO or some financial manager. Yes, they can prefer items, but it doesn't go far if it costs the hospital money. And if it does cost the hospital money, in fairness, the hospital goes bankrupt. Then nobody uses it. So we wrote a little paper. It's really simple. This is not complicated, but you'd be surprised how the 3 takeaways that are really in need in the space: driving efficiency, These little boxes of just cost reductions. This isn't complicated. Savings prevented from costly events, and then replacement savings. Carlos talked about getting patients out of the hospital. I can't tell you, that is the biggest issue in healthcare right now. Because these patients, from a medical and patient standpoint, if patients are backed up in the hospital, and when I was at Northwestern, they were backed up, they couldn't get into the emergency room because patients can't get discharged. Doesn't matter what great technology you had, if they don't get into the hospital, they can't get treated. So I would encourage all of us to think about that, and then I'll kind of, end where I began here. It sounds daunting, all the stuff I went through, and that was sort of a whirlwind in my own life, but I think it touched on a lot of things, and I hope I could share some of the counterintuitives that I only had to learn the hard way through a lot of failures in bouncing through all of these domains. And I think, again, the biggest, I would encourage all of us in these smart minds to think not only about the technology and the physiology, but devices that address specifically the economic condition of the hospital system. There's a real need for intelligent people to apply the engineering mindset to solve financial problems. I've done that. And that doesn't mean just going into spreadsheets or going to the business school. It means designing devices maybe that are inherently easier to use. Designing devices that are inherently cheaper, inherently faster. That's something we often miss as engineers. I certainly did through the vast majority of my career, but there's a tremendous opportunity, including at Solventum. I look for technologies that do that specifically, because if they do, I know there's not many. And it'll take off, and it'll be scalable just like the manufacturer was, in contrast to the artisan. So that's maybe the quick takeaway on Solventum. And again, this might sound overwhelming, but it's really not. It started, like I said, in me coming to the parking lot there. I'm still the same person. And I still want, that is what orients me, and I can tell this is where we need to have the university help us. We don't have the creativity. We don't have the depth of knowledge in industry. That's where we have to have the partnerships. So again, I wanted to kind of end where I began. Again, I recently learned that the Radcliffe Infirmary went to business school in Oxford, closed after about 300 years. So the physical legacy of that trial will eventually fade away. But what endures is the impact, and I want to orient you to the important work that we're talking about here. The impact is what this conference, it's what the Devices Center, it's what the university, it's what my company, and what all of us attendees are actually here for. It's impact. How do we make that impact? And I'm going to give all of you a challenge for the rest of the conference, and maybe for the rest of your career. Refuse to stay in your lane. Refuse to stay in your lane. I did that for a long time, but when I got out of it, this is what opened up everything that I'm talking about here. If you're an academic, go find somebody from industry. Talk to them. Ask them. What's your world like? Why might your latest research not survive in the real world? Be humble. I wasn't. I had to learn the hard way. If you're an engineer, find a clinician and ask them what incredibly unglamorous problem, like wounds, is ruining their Tuesday. If you're a corporate executive like me, go sit down with the basic scientists. You can be darn sure I will after I'm done up here. And so don't just talk to the people in your own field. Don't talk to the people from your own institution. Take an adventure into an alternative path. I didn't choose that. I'm not smart enough. I was forced into it. But just like that random detour into a decrepit business school hallway basement, that's where the magic happens. That's where it happened for me. And we don't want to just invent medical devices. We don't want to just design or build them. We don't want to just scale them or lower costs or enhance profit margins, generate revenue. We're called to enhance people's lives. That's what we're here to do. And you can't scale a solution without crossing the aisle, doing the messy, uncomfortable work of collaborating with people who think entirely differently than you do. And I'll say it's easy to chase the spotlight. I did that throughout much of my career, but what a profound privilege it would be to somehow live up to the quiet enduring weight of what was left behind when they finally closed the doors at that Radcliffe Infirmary, that quite a legacy. It was so pivotal to me crossing the aisle, important to my life and important to the history of medicine. But take a look at this right here. We lost the, take a look at this right here. Little unadorned piece of metal. I don't know if you can read that on the right. It's on an empty brick wall. It's almost jarring, isn't it, how small it is? That's the very building where the most monumental world-changing medical discovery in the 20th century took place, certainly the most monumental clinical trial, altered the trajectory of human survival beyond words. It's memorialized by something so small, so completely insignificant. And it's largely forgotten by the world passing by. And doesn't list the titles, doesn't list the revenues, doesn't list the accolades. It just leaves us with this. And for me personally, the greatest hope is to live a life and to contribute to this meeting, to my company, to those we serve, in a way that's deserving of those prideless words stamped into that little piece of metal brass, as it says, to honor all those who cared for the sick. So let that be our mission. Thank you.